Dr. Wild, is it unethical for people in late stage HD to be in clinical trials? I ask because late stage HD is typically on the exclusion criteria list.
It is not. It absolutely isn't. In fact, I would argue the opposite, that it is unethical for late stage HD people to be excluded from clinical trials if there is a chance that those trials can be conducted in a way that is safe and meaningful. So then why are people with late stage HD typically excluded? The answer comes back to what I was saying earlier on about this idea of the focus of trials being on early manifest HD according to the old system, or stage 3 according to the ISS. And the reason is that if you just think about the symptoms of HD and what we're trying to achieve, in early HD, by which we mean people who've had symptoms for maybe between 1 and 3 years, 4 or 5 years maybe. So they're still functioning in everyday life, but they obviously have symptoms of the disease. So what's happening in them is they've got a measurable amount of effective Huntington's disease. So if we do a motor examination, they don't score 0 or 1 or 2, they're scoring something 10 or more. And that means if we halt the progression of their Huntington's disease, their 10 at baseline will still be a 10 a year or 2 later, and we know we've done something meaningful. But if the drug turns out to be harmful and is making the symptoms of Huntington's disease worse, that 10 might become a 60, but the people on placebo are still only at a sort of 15 or 20 a year later, if that makes sense. So but the other thing about the people with brains with early manifest HD is that they are relatively healthy compared to later, and therefore we believe that the drugs will have a good chance of being able to prove that they're working. But also, if the drug's making it worse, you can measure the deterioration more effectively. When someone's in a later stage of Huntington's disease, what tends to happen is that the ways that we measure HD, that in early to moderate HD, there tends to be like a fairly steady year-on-year progression. But in late stage Huntington's disease or advanced HD, things can often plateau for a long time. People can enter a stage where they're not changing much from day to week to month or even year after year. They're clearly not getting better and they don't have great functioning, but things are not changing rapidly. And that's a big problem in itself, because to run a trial over a year, you have to expect people to change over a year, and then you have to be able to alter that change using your drug, which is much, much harder to do in late stage HD, where things are moving much more slowly or are plateaued. The other thing is, in terms of making things worse, if someone with early stage HD has some kind of bad side effect of the drug, you could stop the drug and there's a good chance that they would bounce back pretty well. Whereas, as we know, people with later stage HD can be much more fragile, and their brains have just much less, bodies frankly have much less recovery potential. So the risk really is, if a drug might be helpful but also might have some side effects, the later stage brains might really struggle to deal with those side effects. So the balance of potential benefits to potential risks is less favorable in people with later HD. And this was seen even in the tominersen program, the Generation HD1 trial. This was all around early HD, but actually there were some old stage 1 patients and some who were a bit more advanced. And overall the trial was negative, but actually if you looked at the data by early versus late within that cohort, it was the people with more advanced HD at the start of the trial who had tended to do worse as a result of treatment with the drug. And I think the way I think about this is that their brains are less resilient to the side effects of the drug. It wasn't that the drug was harming them, was more harmful in them. It was that their brains were less able to deal with the potential challenge that the drug represented to the brain. So what about ethics? So the other issue is that people with advanced HD have trouble understanding sometimes and generally have trouble communicating. However, in the UK, we have a pretty sensible framework, which is basically that we view it as unethical to deny research participation and the opportunity to help others to someone who had a very clearly stated attitude that they would want to take part in research. And this has been really instrumental in things like Alzheimer's disease research in the UK, where it's a much more rapidly progressive disease. So almost always you need to be enrolling people in research who may not have the full mental capacity to understand the research that they're signing up for. So we rely on their families being honest representatives of what that person would have wanted if they were able to understand fully. And most people are able to understand that they're really not keen on on having something done to them. And so there's always a caveat that even if the family wants them to do something, if that person's screaming every time you go near them with a needle, then it's unethical to do it. In other countries, interestingly, it's seen as unethical to involve people in research if their condition, their brain disease is so advanced that they're not able to consent to it directly. And that basically comes down to differences in the cultural and historical ways that these ethical frameworks have developed, and different countries have different attitudes. But I think that the one that's more sensible really is to say, if someone clearly would have wanted to participate and there's no evidence that's changed, and if you can do that research in a way that's minimally uncomfortable, then they should be allowed to participate. Where does this leave us? Does it mean that there's never going to be trials in advanced disease? Absolutely not. And I know that one of the things that was said relatively early on in the Tommy Nursing program, which I think could have been better said, was that bad news, everyone, the Generation HD1 trial has read out negative. And even worse news is that the people in the trial who were more advanced did particularly badly. We need to have a rethink and maybe test this drug in earlier disease. And then I think people have maybe got from that the sense that disease-modifying drugs will never work for more advanced Huntington's disease. Actually, it was always the intention, and it still is, that basically you have to demonstrate that a drug works at all in anyone rather than not working in anyone. And so you have to really focus your early development efforts and your kind of big money on proving that the drug works in the people it's most likely to work in, which at the moment is people with relatively early disease. Once you've assigned that is happening, then I think there is a moral duty to go earlier in the disease, including pediatric and juvenile HD, including prevention trials, and later in the disease. We don't know what is possible in someone with advanced HD. If we stop the disease in its tracks, what will we see? And anything's possible. We might see no benefit. It might just be too late. Or we might see a slowing of progression, which could mean different things for different people. But for some people, that could mean that a life that is very distressing for that person could be prolonged, and we don't want to be prolonging distress. Equally, we could see a slowing which preserves meaningful function and quality of life. And it's theoretically possible that we could see some improvement. And that has been seen in some animal models of HD. We need to be realistic about what could be achieved in advanced HD. And we also need to bear in mind that because we need to run as many trials as possible of as many good drugs as possible. And what that means is each trial, until you know that something works, each trial needs to be focused on the smallest number of people necessary to test that drug, and to do so as efficiently as possible. And right now that means going into early HD. But everyone, and I think it's something that we can easily gloss over because we just publish these criteria, but a lot of thought goes into it. And there is also a universal, broader strategic aim, which is no one is free until everyone is free. And so a drug needs to be tested in as many people as possible who might be able to benefit from it as soon as we know that it's heading in the right direction.
Very good. Thank you for that, Dr. Wild. The next question, we have heard about trials for symptom management, cognitive, and movements. Are there any trials going on for psychiatric symptoms?
It's a really important question and a great question, Rachel. And the answer is yes, but not many. And the reason is that actually the psychiatric manifestations of HD, and I don't want to be blasé about this because clearly they are hugely problematic for lots of people, and even that's an understatement. But they're actually among the things that are already the more treatable aspects of HD in many cases, not universally. And that's because the things that people with HD get are often things that people with standalone psychiatric problems get. Things like depression, anxiety, apathy, psychotic symptoms, hallucinations, obsessions, compulsions. This is quite a cheerful shopping list, and aggressive behavior and that kind of stuff. But actually, we have quite a big toolkit of psychiatric drugs. And because HD has been treated by psychiatrists and neurologists for quite a while, many of those drugs have entered standard clinical practice without going through clinical trials. So in my practice, I use a lot of olanzapine, which is an antipsychotic. I use a bunch of antidepressants. I use a bunch of anti-anxiety drugs. And so those are, but almost none of them have actually gone through clinical trials. And the reason is it would almost be unethical to do those trials because they're giving people a placebo when we know that the drugs work is difficult. But then there obviously are ways of proving our kind of general consensus that these drugs work, but it's very expensive to run those trials. And if the drug's already licensed and many of these drugs are off patent, there isn't really anyone who wants to pay to prove that an antidepressant treats depression and anxiety and Huntington's disease when actually we're giving those drugs anyway already to people. There are trials ongoing. I looked at, if anyone wants to, you can, if you Google Huntington's disease clinical trials corner, which is an article, a regular article series that I do with my colleague, Carlos Estefes Fraga, who's one of the clinical fellows in my department, and Sarah Tabrizi. And this has a complete list of every drug trial that's currently being run in HD. And on that list, there's a couple of psychiatric drugs, psychotics. There was also a trial of, I forgot what it's called. It was a stop smoking drug. What's that one called? That was for apathy and Huntington's disease, and that was being run out of Germany. Oh, someone can post a comment below if they remember the name of it. That, I think that trial was run in Germany and has been completed, and I think it was negative, unfortunately, because apathy is a very tough nut to crack. But these things are being done, but they're much less common than trials of disease-modifying drugs, for sure.